On behalf of Teleflex, I'd like to welcome you to tonight's presentation entitled Why Torque Matters, Integrating Torqueable Microcatheters in Your Practice. My name is Dr. Eric Ryer, and I'll be your host tonight for this presentation. Please let me welcome Dr. Salman Arain. Dr. Arain is an interventional cardiologist at Memorial Hermann Texas Medical Center and an associate professor in the Department of Medicine at the University of Texas Health Sciences Center in Houston. He joined the faculty at University of Texas in 2014, though prior to that, he was on faculty at Tulane University in New Orleans. He currently serves as the program director of the Interventional Cardiology Fellowship Program at University of Texas. Dr. Arain's clinical interests include complex coronary procedures such as PCI for chronic total occlusions, unprotected left main, and multivessel coronary artery disease in patients with failing ventricles. He has presented his cases both nationally and internationally. He has a busy practice in Houston that involves complex procedures and cutting-edge techniques. His other interests include mechanical circulatory devices and their use during PCI, peripheral arterial interventions, critical limb ischemia, and limb salvage. Dr. Arain is the author of multiple journal articles and is an investigator for several trials and registries at University of Texas. He is a fellow of the American College of Cardiology and the Society for Cardiovascular Angiography and Intervention. He has received multiple teaching awards during his academic career. Please let me welcome Dr. Salman Arain.
Thank you very much, Eric. I'd like to welcome all of the audience members to this presentation. It's always unusual doing this in this new webinar format that we've become accustomed to in 2020, but it's great to see you all out there, even though I can't really see you all out there. I want to start by thanking the folks at Teleflex for giving me this opportunity. Today we'll talk about microcatheters and a very specific kind of microcatheter. The title of the talk is Why Torque Matters, Integrating Microcatheters, Torqueable Microcatheters in Your Practice, and there's some information about me. So I can go to the next. Okay, just financial disclosure. I do speak on behalf of Teleflex. There's pertinent to this conference, this presentation, nothing to do with Boston Scientific, but I do talk for them also. The views and opinions expressed in this material are my own and not those of the University of Texas. Though I think the university is kind of happy I do these kind of cases. All right, so, you know, the world I live in is a world of complex coronary interventions. And if you think about it, you know, that's a really sort of broad term. So when we talk about complex coronary interventions, what type of procedures are we really envisioning? And see, here are some of the common clinical challenges that you kind of face when dealing with someone who has either complex stenoses or lesion subsets that we may or may not touch upon tonight. And so you know that you're going to perhaps need a guide catheter that's a little bit more supportive than your usual guide catheter. There may be some issues with guide wire deliverability and support. You may need to use multiple guide wires if you're dealing with a bifurcation or trifurcation. There's often complex anatomy that's involved, some retroflex turns, some sort of high angulations. More often than not, there's actually calcium at these angulations. That makes it a little bit more challenging. Device delivery becomes an issue because many times you're dealing with lesions that are fairly distal within the vessel. So you have to traverse the proximal half or proximal third of the artery. That can be tough sometimes. Vessel preparation offers its own sort of unique challenges. Many times, you know, there's calcification. Sometimes you're working through and past the dissections. And so there's all kind of issues with that. And ultimately, you know, the goal, which is to deploy a stent optimally, that itself may have certain challenges. So these are some of the issues that come up when you're dealing with the case. Another way to think about it is, if you are having one of these issues, then you're probably dealing with a complex situation. And if you have two of these issues, then you're definitely dealing with a complex situation. So the way I like to break it down for all PCIs, and to be honest, any other intervention that you may do in the cath lab, is the C, the P, and the T. So the C is crossing the lesion. So today's talk is going to focus mostly on crossing the stenosis, but that's just the first step. You know, that once you're done with that step, then you can start planning, you know, how you're going to prep and treat the lesion. But really, for many complex procedures, most of us get hung up on the C because crossing the stenosis becomes difficult. Once you've crossed the stenosis, then you come to the P, which is prepare the stenosis. And that in itself is a different topic for a different day, but that has its own challenges. And then there's actually the treat the lesion. How do you then go ahead and do some definitive therapies? Do you atherectomy and all that kind of stuff? So again, there's the C, the P, and the T, but today we're going to focus on the C. So the challenges in crossing the stenosis more often than not have to do with the anatomy of the artery, the path you have to take, and oftentimes the type and degree of obstruction that you have. So these, are some of the issues: is vessel tortuosity, angulated takeoffs, calcium, and occlusions. And really, the way to overcome these, we have these strategies. So we have specialized wires, we have specialized microcatheters, and then there's a technique on how you use these. And as we talk more about these Torqueable microcatheters, I think it'll become apparent that these are not the way we're used to dealing with microcatheters. This is not an over-the-wire balloon that you can just slide along the wire. This is actually a microcatheter. You can actually make the catheter do certain things to your advantage. Similar thing with the wires. I mean, there are workhorse wires, that we use for most of our run-of-the-mill cases. But once you start dealing with some of these complex cases, you have special wires, and the different ways you torque them, it might be a little bit more nuanced, or you might have different techniques for torquing them. So you have the technique there. Now, the microcatheters can help challenge these, can help you in this by doing a few things, and those are listed here. So for example, maintaining wire access. So you've done some crazy maneuvers, you've got the wire across, but now you need to change for a support wire. Perhaps you want to do atherectomy. The microcatheter lets you do that. Sometimes it's delivery of therapeutics. Maybe you just want to give some medication down there. Sometimes you want to inject contrast to make sure you're in the proper lumen, just to make sure you're not in the, in the dissection plane before you go in an angioplasty. And then enhanced guide wire steering and support. What this means is that the microcatheter allows you to get across these complex stenoses. And many times, one of the issues is that if you are far distal in a very angulated vessel, you really can't torque the wire, or you start losing torque responsiveness. And the reason for that is, even with the good wires, some of the sort of one-to-one torque wires, the issue is that the vessel is gripping the wire at multiple points. So what the microcatheter does is isolate the wire from the vessel and allow you to sort of torque and maintain that sort of torqueability, which becomes really important when you're trying to make some sharp angulations and whatnot. Improve the penetration power of guide wires. Another point, many of us use wires that have a certain strength associated with them. The Confions are 9, for example, or the Confions up to 12. Well, what does this mean? Well, that's the amount of force you can put at the tip of the wire. But what a lot of people don't realize is that's the force at the tip of the wire if the wire is held a millimeter behind the tip. So most of the times we're working without a microcatheter. The wire comes out of the guide, and now you're trying to deal with a stenosis or subtotal occlusion or whatnot further down. And when you try to torque this wire, what ends up happening is you just don't get that pushability. So you think you're using a pretty supportive, maybe high penetration wire, but it's not penetrating. Why? Because much of that torque is being lost because the wire is buckling in the proximal vessel. But what microcatheters allow you to do is basically stiffen that part of the shaft so you get close to the tip of the wire, and that's where the wire is then able to exert its 9 grams or 3 grams or 12 grams or whatever sort of penetration force that is designed to exert. It can do that. So again, if you're having issues with a wire that's not penetrating, perhaps a microcatheter is the solution there. And then finally, change wire direction. And that's important because sometimes, or many times for these complex stenoses, what you need a different shape to get into the lesion and a different shape to get out of the lesion, or perhaps a different shape, maybe a much wider curve to get from the left main into, say, a retroflex circumflex artery. But once you're in there, you need a much tighter curve to get into perhaps an OM branch. And so one way you can do this is to use the microcatheter, and you can take the wire and reshape the same wire, or perhaps go ahead and get a new wire. So again, here are some solutions. Here's some of the techniques, and here's some of the options that microcatheters allow you to exercise in these PCIs. All right. So I mean, we talk about microcatheters, but why torqueable microcatheters, and what makes them torqueable? Well, to get to that point, you have to understand what makes a microcatheter. And so a lot of us think of microcatheters as a sort of maybe a tube of plastic that's reinforced, maybe has a marker at the tip. And that's our classic, for example, the Mini is one of those catheters. Those are microcatheters oftentimes we use in the periphery. And those are polymer only. This is a straightforward transit catheter. It gives wire support, and you can use it to change out wires. Once you deal with complex stenoses, however, you realize you need specialized catheters. So then there's this whole concept of the braided catheter. And typically what this involves is an inner PTFE core, which kind of allows free movement of the wire. And then you have a sort of a braid on the outside. So these are like mini guides, if you will. So there you can have a stiff braid, or you can have not a stiff braid. And that gives you some flexibility, but also gives you support. And some of these stiff braided wires can be shaped into specialized tips. So for example, the Supercross catheters is a family of catheters that can get you through these very tight angulations, and those are braided catheters. So not so much for torquing, but they can be advanced over the wire. They can be torqued to a certain degree to change the direction of the tip, and then change out wires. And they're mostly for microchannels and the tortuosities. So the catheters that we're going to focus on today are actually the coil and braid. Now these obviously are fantastic, and the magic for these catheters, or the secret sauce in these, is that the coil, and we'll talk a bit about that. And so what these allow you to do is not only can you advance these catheters, but you can actually torque them either antegrade or retrograde, depending on what the situation is, and actually get these catheters to advance. And sometimes, there are situations in which the catheter tip meets somewhat of a stenosis or narrowing, and you just can't push it, because the more you push the catheter, these being braided and somewhat flexible, start sort of buckling up. But what you can do is you can actually rotate these catheters, and there's a sort of inherent sort of buildup of energy, and that sort of kinetic energy at this end becomes potential energy that gets transmitted to the tip of the catheter, and the catheter releases that energy by moving forward. So it actually gives you a little bit more pushability and can really make your life easier in some of these cases. All right, so here's the microcatheter spectrum, and here you can see on one end we have the polymer only. They're simple, they're cost effective, they're often used for transit. This is the mini support catheter. There's some other brands that obviously every company has. Here's one that only has braids. These have some flexibility on account of the braid. They're a little bit more pushable perhaps, but again, they really don't let you get through very tortuous anatomy. They're more for making sort of specialized bends and turns. And then you have the braid and coil, and this is where most of the discussion is going to be focused on. So these are workhorse in the complex cases, and what I've found is really, for me, complex at one time meant chronic total occlusions, then it meant subtotal occlusions, and now, even everyday cases, I find myself using these microcatheters. So it doesn't really have to be an occluded vessel. It can be a subtotally occluded vessel, sometimes acute MIs, sometimes something happens. You engage a guide, and next thing you know, there's a guide-induced dissection. That's a fairly complex case right there, and that's where some of these microcatheters will help. So they've become workhorse for me in pretty much all of my cases, not only the complex PCIs. And here we'll talk about the Turnpike and the Turnpike LP. Now, there are situations where you have to make a turn with some aggressiveness, and one example that comes to mind is perhaps you're going down a graft, and for whatever reason now you have to make a retroflex turn to perhaps fix the more proximal area of the graft. For example, there's a vein graft going to an OM2, but there's a retroflex portion which feeds the OM3. You want to fix that. Well, you might find that the smaller Turnpike catheters tend to prolapse across that really tight bend. What these external threaded coils allow you to do is that there's almost like an external grip. There's another sort of braiding on the outside, and this actually functions like a screw. And you can only turn these catheters in one direction, but what it does allow is gives you this additional rotational assistance and allow you to cross and make that tight bend without prolapsing. So again, there is a value to these external threaded coils. And then you have specialty catheters, which is not the focus of this talk, but I absolutely love these. And here is the twin pass. It's a twin pass which has dual lumens, and there's a whole separate talk. Someday we'll talk about those. Okay. Most of my complex cases, I go back and forth between these two wires. So I would say that 80 to 90% of my complex cases, I usually complete those with a braid and caul wire and with a specialty catheter or the dual lumen catheter. Yes, there are situations I use, external threaded coil, much less now. And there are situations where I may actually use just the braid, but more often than not, these are the two that I go back and forth between. Okay, so if I can get this to work. All right, so just to put it all together, basically in everyday life, if you're someone who deals with coronaries on a regular basis, and especially complex coronaries, there are three types of catheters. There are catheters you push, catheters you torque, and then catheters that let you do cool things in addition to torquing, such as make sharp bends and change multiple wires and deliver therapeutic agents and medication. So for me, I think, these catheters that we torque are probably what really have changed the scope of my practice. Well, how does this work? So why do we keep talking about the torque, and what's so special about this torqueable catheter? So what the torque allows you to do, like I said, is advance the catheter forward on the wire. This is both an active and a passive, and there's a video to show this maneuver, though I think it's more passive than active, which is wonderful. The advantage of using torque, it disengages the catheter from the vessel wall and reduces friction, makes wire movement free. It allows the catheter to make sharp bends and enables the catheter to push through. And this is where that sort of potential energy becoming kinetic energy comes in. Now, the caveat is, to see all of these advantages, you have to have adequate support. And just like I said, with these wires, you need the support of a microcatheter. Well, the microcatheter itself needs adequate support to function optimally. And that usually means guide catheters, guide wires, guide extensions, and anchors. And these are some techniques that may be familiar to many of the folks in the audience. We won't talk about these, but sometimes, I'm just going to say this, that if you feel that your microcatheter is not behaving the way you expected it to, perhaps it's a lack of support. And one of these things may help you build support and allow the microcatheter then do what it's supposed to do. How this works is, as you can see here, that you've got this tortuous lesion. You've got enough space that the microcatheter can potentially prolapse. And as you sort of actively slide the microcatheter along the wire, a point comes at which the microcatheter just won't advance. At that point, if you just push the catheter forward, chances are that either you push the guide out, which is very common, or if you have enough room, such as, for example, a wide left main or a wide LAD, the catheter may prolapse down the artery. Now, you can prevent this by using stiffer wire, but even so, this is usually not enough to get the catheter across. So at that point, what you can do is you can start torquing. And what torquing allows you to do is this torque builds up, and you might notice some sort of stiffening of the catheter. You might need some buckling, but that's usually limited. And at some point, you will notice that the catheter starts to move forward. And as it does, you can see that the catheter sort of almost releases itself and makes its way through the lesion. And that's sort of the whole principle behind how torque works. Now, I'll show you the design of how one of these catheters is made. But the beauty of this microcatheter, the Turnpike and the Turnpike LP, compared to some of the other ones I've used, is you can actually torque this in any direction. So whether you torque it clockwise or counterclockwise, the catheter only goes forward, and that's wonderful. And so sometimes what will happen is, if I'm torquing and I find that the catheter is now threatening to buckle or pretzel and prolapse into the vessel, I'll just reverse torque, and that then pushes the catheter forward. So in any given sort of case, I may be torquing it backwards and forwards, or clockwise and counterclockwise multiple times, just to make sure the torque keeps getting transmitted. This actually is one of my favorite slides, and it's mind-blowing, because until I saw this slide, I didn't realize the exact mechanism of how it works. So let's deconstruct this slide a bit, which itself is a deconstruction of one of these catheters. So the innermost layer is a PTFE liner. That's why it needs to be flushed. It needs to be completely wet, and more often than not, the hydrophilicity of the wire and this PTFE tube makes wire patches smooth. And that's why you can actually rotate this catheter without holding onto the wire, and the catheter will move along the wire without pushing it forward. And so that's one of the nice things that you can do. You have a braid. This is what the braid looks like. Like I said, many catheters come with this braid. This reinforces it and maybe allows some flexibility, prevents the catheter from kinking. But the magic happens here with these bidirectional coils. These coils, you have an inner layer and then there's an outer layer. And now those of you who've actually felt or actually held one of these catheters in your hands know how amazing it is, because there's so much construction in such a small space. But these two coils are what make the catheter or give it its features. And then the outermost layer is a polymer coated. It's got a coating of hydrophilic material on it and makes it sort of slippery and able to get across. But this is what makes the catheters actually move forward. And when you rotate clockwise, and you can imagine this, the outer coil contracts while the inner coil expands. So as you're doing clockwise, these are coming apart and expanding outward. These are tightening up. And at some point, the contracting outer tube meets the expanding inner tube. And at that point, if you impart more energy into the system, it just extends it forward. And that's what basically gives it the grip and the ability to transmit torque from the hub all the way down to the tip and move forward. And when you reverse torque, so now you're going in the other direction, now you're going counterclock, well, guess what? Now the inner coil, because of its direction, that contracts while the outer one expands. And so what this does is this grips the outermost coating, and this goes ahead and grips the inner braid. And that then allows you to lock the catheter and transmit that torque down the length of the catheter. So whichever direction you torque in, within limits, as long as you don't over torque, I think as long as you torque to a reasonable degree, you'll find that the ultimate or the eventual effect is to push the catheter along the wire. And the nice thing is, because of this PTFE coating, though, and I'll show you some cases, the catheter moves forward without the wire moving forward, because sometimes you're working with very stiff wires, and the last thing you need is this torque to kind of push the wire forward also. One of the things that often I think people aren't taught, unfortunately, or maybe they see the operators using these catheters but don't know this part, is how to actually hold the catheter. What's the exact position? What's the proper way to hold these? So here's a demonstration. This is a desktop or a benchtop model. You can see here there's a wire, there's a microcatheter, there's that hub. And you can see I'm going to pause this video in a few points. So right off the bat, I want you, oops. If I can pause it right there, I want you to notice how the operator, so this is an overhanded sort of position. So you've got your one hand on the hub, you've got the other, you're holding the catheter itself, because this hand is going to push. As you torque, this hand does not need to torque. Now, there are some microcatheters out there where you actually have to torque with both hands. But the nice thing about this microcatheter is you don't have to go crazy torquing with both hands. This hand stabilizes the guide. It stabilizes itself against the guardian or the hub, whatever you're using. And here you've got the catheter that gently being pinched or held by these two fingers. This hand comes sort of in this overhanded way where it kind of goes and hooks it from below. And the whole idea is that you're actually going to use the forefinger and the thumb to actually spin this. But you really want this wire to come through, and you want to feel this wire against your middle finger and your little finger, because that'll tell you if the wire is now threatening to buckle or if the wire is moving forward, because you'd be able to feel it. What I personally do is often have a torquer park at this point, because sometimes it's not easy to feel the wire. But if I have a torquer here, then when I hold it, I can actually hear the torque. I can actually feel the torquer with this finger. And if the torquer starts moving forward or starts moving back, I know that the wire is probably losing position. So there you go. And typically that's where I would have the torquer. I hook it, and at that point you start rotating, and this hand is rotating while this hand, as you can see, is pushing forward. And as the catheter moves forward, you just readjust this hand, the right hand, and you can do it. Now, in this particular case, it's subtle, but if you notice, and I'll let this play one more time, you can oftentimes aid the forward motion by actually by pushing out the thumb. So here, if you focus on the thumb here, you can see you're rotating, but then as the catheter starts moving, you might actually rotate and sort of push forward just a bit, just like that. And at some point, you'll realize that the catheter starts moving freely. And then you can do this as many times as you need to. Sometimes you do this, you advance the wire a bit more, then you do this a little bit more until you make your way across the actual complex stenosis. All right, so before we talk about the cases, I just want to go ahead and tell you that there are 4 different flavors of the Turnpike catheter. You know, it's interesting. I would say that by and large, many of my cases tend to involve the low profile one, the LP. I used to go back and forth between the standard and the LP, and I found that the LP does pretty much whatever the standard can do, and perhaps go into tighter spots. Both of these can be rotated in either direction. The spiral here has this external coil we were talking about. So this is a coil on the outside of the catheter. It says there's sort of a rib sensation. You can actually feel it. What this does, you can see it's only in one direction. So this is the sort of catheter that you want for some of those complex lesions, which have room for the catheter to go forward, but you need some pushability. You need a little bit more support. These can only be turned in one direction. And then there's the Turnpike Gold, which actually has a metal sort of tip, which actually has a little bit more better defined screw. And these can be used for some of this fibrocalcific stenoses. It's interesting, but it seems that whenever I use, I'll end up switching to one of these 2 catheters to complete the rest of the crossing. And that's just because this is somewhat bulky. So again, you'll find that in some cases you may actually need 2 of these catheters, and that's okay, because ultimately you're trying to do a very complicated stenosis. But by and large, many of my cases involve the LP or the standard Turnpike. So here's our first case, and I'm actually going to pause this here, and it's one of my earlier cases. I don't have as many fluoro saved. It's only 4 slides, but the reason this case is important is I don't want to show you this for the catheter, for what the catheter did. I want to show this to you to show you what other catheters did not do. So this is a patient who's had bypass, has had valve fixed. And they were referred to us by one of my colleagues in the community, and they said that they were able to. Let me just play that one more time here. Ooh, maybe I shouldn't have paused it. So what I'll do is I'll go back and we'll come back to the slide. That might make it work. Okay, and so they said that they were using one of these sort of hydrophilic wires that got it across this proximal lesion, but they were then unable to get across the distal lesion. And then they tried to use an over-the-wire balloon, and they found that the over-the-wire balloon got stuck at the proximal lesion. Now, let me see if I can pause it right there. And you can see that this is actually a very complex lesion. You've got calcification that actually is within the vessel wall. These seem to be 2 separate stenoses, but as I like to teach many of my fellows, this is probably just one big chunk of calcium that's actually an exoskeleton. So this vessel has a cast, there's an exoskeleton that extends all the way here. What you don't see is the calcium spiral around, and here it sort of cuts across, but it's actually spiraling around the LAD as it comes down, and there's some calcium here too. But what's really happening here is that an over-the-wire balloon is just too stiff. It just won't make this. And this particular person who referred the case then actually said, well, we tried to use one of these microcatheters that was, I think they were using a fine cross or something like that, but this one of these sort of non-braided, non-torqueable microcatheters, and they said that the catheter would get stuck in this proximal stenosis, and the guide would keep getting pushed out. And again, you can see the reason for that. The reason is you really don't have enough support. So even if you had a wire there, a hydrophilic wire, you're still in the soft part of this wire, and you just don't have enough support to get one of these sort of catheters across. And even if you did get these microcatheters across, you'd probably get stuck here because this is a very tight sort of lesion there. So the question is, how do we treat these? And having the advantage of the previous angiogram, we did a few things. This is actually the 6 French guide. We could have used the 7 French guide, but we built up support. So we have a long sheet, we have 6 French guide. It's an EBU, slightly oversized, so it's really wedged in there. So you have a lot of support. Obviously, it's not coaxial, but all I have to do is pull the EBU back. But here, I'm going to use a microcatheter just from the get-go, because a torqueable microcatheter, because I know that I may have some issues here, but I'll certainly have issues getting across here. The wire that we used here actually turned out to be our standard workhorse. Well, what's standard for me now? It's actually one of the Scion wires, or Scion. And the idea here is that even though in my mind, I had anticipated using one of these tapered tip wires, tapered tip hydrophilic wire, maybe to get across there, I wanted the Scion, because of its atraumatic nature, to be parked there as I got the microcatheter across. And I'm apologize for not having this next video, but what we found is that just with the support of the microcatheter was enough support for this wire to flop across, or pass it forward. And then as we drove this microcatheter down, the wire just kept moving forward freely, so we knew we're in the true lumen, and we just used this standard workhorse wire and the microcatheter to get across. And again, it's a little hard to tell here, but you can see the guide position has changed a bit. You know, maybe I pulled it back, maybe I pushed it to make it more coaxial, but the guide's a little deeper. So with this extra support and with the torque of this catheter, we were then able to get across. Once you were across, then you just have to go obviously you can either do a tip injection, or you can basically aspirate and make sure there's some blood there, get a wire across. And then the next thing, we were able to switch out for a rhoda wire. Obviously, it's difficult to imagine doing the stenosis without some type of prep atherectomy. And here's our final result there. Now, this case is from about 3 years ago. My technique has changed somewhat, and one of the things you can see that the proximal stenosis is still a little underexpanded. I think these days we might use something like laser. In the future, we might have something like shockwave. But you know, when we IVUSed, I think we had a decent residual lumen there. And this guy here, if I can play that again, has really good flow. Let's go back one. Ooh. Well, we all saw it. It looked marvelous. Try one more time. There we go. And you can see that the distal lesion has expanded completely. The center has completely expanded. Proximal, not so much. But again, this is just one lesion, and one single stent did the trick. And here again, it's not so much what the microcatheter was able to do, the Turnpike. I think what's more impressive here, or the take-home point, is that over-the-wire balloons and the standard microcatheters may not be adequate for complex anatomy like this. Or if you try those first, and that's reasonable too, you find that perhaps you're not getting success. Maybe it's time to switch out to a Torqueable microcatheter. So here's a different case. This is interesting. This is someone who basically has had prior work done. They've got that proximal LAD stenosis. They've got a total occlusion, it would seem, that in the mid circumflex. But this is actually in-stent restenosis. And again, the teaching point here that many of these in-stent restenoses are not total occlusions so much as there are subtotal occlusions. And many times, if you were able to, use a hydrophilic wire and get it up to that point, you can actually then slide that across. So here, the first thing to do is get the microcatheter in position. So, there's some angulation involved. And one of the issues here, as you can see, is that the circumflex ostium comes off from behind that left main LAD stent. And so what you can do is you can just pass a wire down. And the nice thing about the microcatheter is that you can actually torque it oftentimes between the cell struts. So that cell size is usually large enough to get between the struts. Once we're in position there, you can see that there, go ahead and take a wire out. Now this is a high resolution image. The wire here actually is a Gaia second. So my preferred wire is oftentimes either a hydrophilic tip wire with a very tight bend, or I found that the Gaia second, because it has a sort of a sharper tip, it can grip and it can actually make its way, scratch along the neointima and go all the way across. The advantage is that sometimes these stents tend to, if I can pause it right there, sometimes these stents tend to be undersized. So the question is, why does the stent get occluded? Many times they're undersized, and these hydrophilic wires will oftentimes get behind the stent struts, and that becomes a bit of an issue. So the advantage of using the microcatheter is A, you can make multiple wire exchanges across that proximal stent. But B, the advantage is you can change out wires without having to cross that proximal lesion every time. And in my case, I preferred a Gaia second just because I think it has properties that let it really sort of cross this neointima sort of fairly quickly. And again, you can see that as the Gaia makes its channel across, as the wire makes its way across the subtotal occlusion, it's not a straight path, and that's just the way the neointima grows. It's never a linear passage across the occluded stent. It's usually like layers of neointima that have grown out, like the rings and rings and rings until you just have a tight central channel that you just have to find that. Once it's in position and the wire won't move forward anymore, I can go ahead and advance my microcatheter, and this often involves torquing. Now, this is our sort of high definition views. Here you can see the actual torquing motion, and I want you to actually, I take that back. This first panel is I've changed out the Gaia for a hydrophilic wire. This is actually a Fielder XT, and what I've done here, I'm going to pause this for a second. What I've done here is actually push it across, and these things are painful. But I want you to see when I push that Fielder across, I'll make the knuckle, and I'll let the knuckle find the rest of its way across that stenosis. So right there, there's your knuckle, and I push it forward. You'll see it in a second. And there we go. So the knuckle goes across, makes its way across the rest of the stent. But now it's there. The Gaia perhaps doesn't have as much support. The Fielder doesn't have as much support in the shaft here. So what I'm now doing is I'm actually torquing this catheter. And as I torque, see what happens to the guide. The guide pushes back. The moment I see that happening, I will reverse my torque. So I'm going counterclockwise perhaps, 10 turns. It starts moving, but then I see this happening. What I'll go ahead and do is I will flip it to clockwise, or clockwise to counterclockwise. Now, what's interesting is what we don't know is where the resistance is if it pauses here. So it could be resistance here that's causing this buckling, could be resistance where the catheter meets the struts, or it could be actually this lack of support here. So at that point, sometimes what I'll do is I'll advance the guide. If this was further down, and if this hadn't, for example, been behind a stent strut, I might have used a guide extender. So I would have used this wire, I would have used the microcatheter, then I would have used the guide extender, and then a support guide. So you can really build up a lot of support to have this catheter function optimally. Once that's done, you can do a distal tip injection to confirm. Here you can see some competitive flow from the other side, and this is the final. So we then went ahead, angioplasty, and we did like this is like a T with protrusion type of strategy there, and you can see this is done. So here again is a fairly sort of complex sort of situation with an ostium that was sort of jailed. Then you have instant restenosis, and then we went and took care of that. Now this is a case, again, this is one of my partner's cases. I wasn't involved, but I actually asked him to share his slides. And this is someone with an acute myocardial infarction. And this is actually one of our first cases in the COVID era. So this patient actually had come in a few days late. He's 46 years old. And as we found, a lot of these patients have organized thrombus, and maybe they missed their symptoms, or maybe they're afraid to come in. But the problem here was a highly tortuous right. And even though you don't see the whole vessel, you can see almost in the REO view, you can see the sort of anterior takeoff, the retroflex proximal portion, and this is somewhat sinusoidal right there. So this is not going to be easy. And he does a lot of radials, and he clearly had issues getting this guide to stay in place as he pushed the wire. And this was organized thrombus, and so he needed a little bit more support. And you can see the problem there. So the wire just went in halfway, and then he really didn't have a whole lot of support. Well, he built that support here, you can see, by doing three things. I'm going to pause this here. He changed out his guide to an AR1. I think while that may not be as deep as perhaps an AL, but I think given the anterior takeoff, I think this was an appropriate choice. He then wanted to make a smoother transition, so he's got a guide extender. I think this is a guide liner. And then he went ahead and put this microcatheter through there. And you can see that by doing these two things, he got a lot more support, and he was then able to pass the same sort of soft tip wire all the way down across its nose into the distal RCA. And then he went ahead, and here you can see that he was able to torque the catheter. And here you can see what he's doing is just torquing the catheter. So he's not pushing the catheter. You can see the wire is not moving at all. And many times if you actually hold on to the wire and then move the catheter, you'll see that the wire will go back and forth. But all he's doing here is torquing, letting the catheter do its job, is roll along here. And you can see the sort of tortuosity against which the catheter is working. Once he did that, he was then able to do angioplasty in the culprit lesion. And here's an interesting image. You see this what looks like a piece of thrombus just get displaced downstream, but he's been able to restore some flow. And this is the final picture there. Now you can see that probably that chunk of thrombus probably went down to the PDA, which I guess wasn't treated in this case. But the point is that here you have a fairly complex sort of situation, acute MI. This has nothing to do with, I mean, this is a chip, but not your typical calcified artery. It's not an older patient with bifurcation. It's not a total occlusion. It's an acute occlusion in a young patient with very tortuous, elastic sort of arteries. And here the microcatheter and some of the other strategies were able to help build the support. Look at the time. I just want to make sure. Ooh, wow. Okay, time's flying. All right. Just to show you that you can also use this in the periphery. Here's a case of a subtotal occlusion of an SFA. I've done similar things in more complex lesions also, something that might be better defined occlusion perhaps. But here, what you can see is I've actually gone ahead and taken some pictures, marked out my path. I do think there's a channel there, but I don't think I can cross this channel with just a glide wire. I want to, okay, so let's talk about this for a second. What I don't want to do here, which is what I would have done in the past, is I don't necessarily want to use a glide wire because I think I may have to knuckle the glide wire. And if I knuckle the glide wire, then I may get subintimal. So I do a lot of, I use drug-coated balloons quite a bit. And so if I can stay intraluminal, I think that would be great. And so the microcatheter allows us to do that. This is an 014 system, there's a crossover sheet. Sometimes I'll put an 035 catheter to give me support. But here you can see I've got that microcatheter down there. And this is actually a Gaia third wire, though many times I'll use a dedicated peripheral wire. Sometimes I might use some other wires, but there's a Gaia third wire, and I use that to engage the tip of this lesion and slowly advance the catheter. In the next slide, you'll see that I'm now rolling this catheter forward, and you can see this buckling. This buckling tells me that I've reached some kind of limit, and it's unlikely that the catheter is going to move forward if I keep doing the same maneuver. If I'm going clockwise, I may go counterclockwise. At that point, the catheter did not move, so I started advancing the wire. And I want to show you something interesting here, and I hope you can see it. Let's see if I can play this again. So this time we're going to focus on the second panel here. And I want you to see that once this catheter stops moving, I am now trying to torque the wire, and the wire itself is not able to cross that sort of microchannel or that sort of short occlusion perhaps. And see what happens with the wire tip. You'll see, I'm going to go back one slide, and then we'll come forward one slide. And it's like, okay. So this is the catheter buckling, and now you'll see the wire move here. And let me see that. I do apologize for this. These video heavy presentations sometimes. Okay. And here. So see right there, the wire is moving forward. I'm trying to dig into it. And as I push forward, the catheter gets pushed back. And right there, you'll see the wire wants to buckle right there. So I know that this is the weak point. The wire may want to buckle here. So all I do is I advance the microcatheter across this point where the wire wants to buckle. And just by doing that, you'll see what happens next. The wire just sort of flies forward. In fact, it makes a nice sort of knuckle here and pushes forward. So between that last panel and this one, all I did was advance the microcatheter, and that gave me that additional pushability or penetrability of that wire to do that. And here's a sort of soft Gaia knuckle to go ahead and knuckles across. And there we go. So once I'm across, and I can do a tip injection. This is our initial angioplasty result. We then went ahead and did DCB, and we then kind of sort of ended the case there. And if need be, we can bring the patient back for stents. All right, so Just before we go into the question and answer session, just a few things. Additional strategies for success is, again, adequate support. Guide must be well engaged. Again, like I said, I use EBU guides for the left, and maybe a JR4 or an AL1 for the right. Ensure that the wire is advanced far enough. The catheter works best in the stiff part, but I'll tell you, as you saw in some of those cases, these catheters can also traverse or walk along the soft part of the wire. Alternate between clockwise and counterclockwise directions. How many times should you turn? I think 10 is enough. It's sometimes hard to keep count. So how I know is by keeping an eye on the first, I might feel something happening to the wire in my hand, but keeping my eye on the guide tip. If the guide starts pushing back, you know that you're reaching some kind of limit there. If the catheter starts to buckle, then that's another clue that you may be reaching some kind of limit on the tensile strength of the catheter itself. Now, some of the catheters, just to remind you, you can only do in the clockwise direction, and that's the spiral and the gold. The other ones you can go clockwise or counterclockwise. If you can help it, do not rotate the catheter more than 2 360-degree turns. Because what ends up happening is, if the catheter does not start moving forward at that point, it tends to fold up on itself and becomes a pretzel. And that pretzel sometimes can lock the catheter in, and it's not a good situation to be in, because then you try to pull on it and the pretzel tightens up. So it's best to basically keep it under 2 full rotations, and then watch out for catheter fatigue, and that's one of the indications. If you see that the catheter is buckling quite a bit, maybe it's your 5th or 6th pass, maybe you're doing multiple stenoses, go ahead and just get a different catheter at that point. What happens if your catheter was advanced? Well, the question is, are you going too slow? Because remember, you've got to impart enough energy. There's a sweet spot. You don't want to go too fast. You don't want to go too slow, but you want to do it at that pace. And that, I think, video showed us the pace at which you want to rotate in one direction than the other. Is the guide backing out? That means maybe you need to advance the guide, maybe choose a different guide, maybe use a guide extender. Perhaps you want to maybe change the direction at that point. Are you on the stiff part of the wire? So if it's possible to advance the wire, then definitely do advance the wire and reattempt. And then the tip's still intact after multiple uses, but sometimes the tip just gets fatigued. So even though the tip is fairly resilient, you might find that actually the tip is pinched a bit, or maybe it has the piece is sort of cracked a bit. So at that point, if the tip is just not playing along, you just have to use a different catheter. For the guide keeps backing out, here are the strategies: enough support. Longer sheets are often not needed. You can build up support in other ways. You can use an extension catheter. If you have room, you can use an anchor balloon. So sometimes you can take a small side branch and put a second wire down there and anchor balloon there. What if your catheter starts advancing, but then it gets stopped somewhere between the stenosis or the collateral? Again, usually support is an issue. If support won't work, then you can try gentle angioplasty. So this may be the point at which you say, you know what, even though I'm treating a 3/0 vessel, I'm going to start off by doing a 1 millimeter or a 125 balloon just to let my catheter go across. Because sometimes just parking the small balloons short of the main part of the stenosis and just doing angioplasty is enough. So it could be maybe that the catheter is stuck behind a stent strut. Maybe it's a little piece of calcium, you just need to get that out of the way. Obviously, if you still have issues, you can actually do microdissection. You can use a balloon, and there's some more advanced techniques we can talk about. And if at all possible, sometimes you can do atherectomy. But these are some of the sort of end stage sort of scenarios where you're close to finishing, you're close to getting across the stenosis or whatever vessel you're in, and the catheter just won't advance. And again, always try a different catheter, a different type, or sometimes a different brand. Sometimes that helps. But more often than not, just switching to a new Turnpike LP will do the trick. Other tips for success, just habits I've picked up over the years doing this. I'll inspect the catheter tip before every insertion just to make sure the tip isn't fatigued. Always flush the catheter because, again, even though this is a PTFE tube, if there's blood in there, the blood will basically, will dry up, and then it becomes very hard to flush it. So sometimes you'll find a catheter you just can't flush. If you can't flush it, then you probably shouldn't be putting it on the wire. Sometimes you can use a trapping balloon. I mean, not sometimes. I do this fairly often. Use a trapping balloon or trap liner to make exchanges. makes life so much easier, and we can talk about that, either after the discussion or in other cases. You can use a guide extension for support. Don't hold the wire while rotating. That's something I don't like to do, because I think if you hold the wire, sometimes the catheter jumps forward. So I think if you keep the wire relatively free in your hand, I think you can rotate the catheter without too much sort of sudden wire movements. And do, again, my opinion, put a torquer on the wire and keep an eye on the wire tip in position. So oftentimes, my eye is going back between 3 points. I'm looking at the catheter. It'll quickly flash to the wire tip, look at the guide catheter, tip, guide catheter. So I'm doing this multiple times as I torque, just to make sure the wire is not shooting forward, the guide is not backing out, and then the catheter itself is not sort of over torquing or trying to sort of bend to become a pretzel. One last case, I just want to show this to you in terms of just what this catheter can do. I think we're almost out of time here, but this is a lady who actually had an ulcer on her digits. And this is a lady with scleroderma, and you can see she has an ulnar occlusion. And her initial attempt to cross the ulnar in this direction was unsuccessful. What you see here is the deep arch. This is superficial arch, and what you don't appreciate is that this is actually a retroflex portion of the vessel. So if I can play that here, you can see what I have to do with this wire just to get that around retroflexed. And I just want to show you, this is totally off the charts kind of here, but what this microcatheter was able to do. So this is a Turnpike LP 150 from the leg going up and down this woman's arm, down the hand, and coming back up. We were then able to do it, and the thing is that the ulcer was on the forefinger. And so what we were then able to do is redirect this wire and go down this arch, and you can see I was able to get all the way down, and really don't even have balloons this big. I mean, how do you treat a fingertip? I don't know how you treat a fingertip. What we ended up doing is using this sort of feeler XT wire, and you can see I'll twist it here to make it a little stiffer, and I'll just dot it through all the way to the fingertip. Now, the case has nothing to do, as fantastic as it is, we're not talking about the hand, we're not talking about the complexity of treating someone's finger ulcer. The point is, just look at what the catheter has done. Just see what the catheter has to do. And you can't push, because if I do push, this happens, right? So the catheter comes, because these are arteries in the hands of a 36-year-old woman, there's a lot of flexibility. There isn't any calcium for the catheter to push against. But the reason I was able to get the catheter all the way across, all the way up here and down into the digit is torque. This is pure torque. I can't take credit for it. Maybe I can take credit for spinning it. But the point is, all of this is wire support and torque, and this catheter was able to get all the way down to this woman's phalanx. And this is, okay, so then the cherry on this, icing of this cake is, we then redirected this into the ulnar. This is now a Gaia 2. It's a beat up Gaia 2. Don't ever do this at home. But this Gaia 2, well, I said if it works with the fingertip, we can try it here. This is a Gaia 2 bent upon itself, making a knuckle. And what you don't realize is that I'm actually pushing here. Nothing is happening until suddenly something does happen and the Gaia pushes through. We were then able to roll the catheter back up here, chain out for stick wire, and do angioplasty and complete it through here. So this is the hand, her ulcer healed. It was a fantastic case. She now has obviously the patent radial. You'll see, oh, we have to go back and come back. Maybe I should, but I just want you to see what the catheter, the Turnpike was able to achieve here. Let's see now. Once that passes, maybe this will play. There we go. Right there. So this microcatheter was able to come all the way down here, make this loop-de-loop, come down here, go up, come down, and do all of this. And then we were able to redirect it across this loop and come back up and then treat this. And so again, I think this is just a testament to the catheter. Okay, so in the interest of time, I think I will stop there, and then we'll take any questions that you all might have. I do have one more case, but I think this is sort of plenty for now. Thank you. Eric, did you want to?
Sorry, I was having a problem with my mute button there. So thank you so much. That was an excellent presentation. I really did love the mix of the coronary and peripheral. We have some excellent questions that have come in. Anybody that does have additional questions, please send them through the Q&A. I'll stay on after this webinar for a while and allow people to put some questions in. I'm going to throw a few short ones at you now, just because we are here at the end of our hour. And the rest of the questions we're not able to get to you, we will send over to Dr. Arain and have those emailed out to everybody so that we do address all the questions. So, one of the first questions is pretty straightforward. What happens if your catheter gets stuck? What do you do?
Well, I think you got to ask yourself, where is it getting stuck? Is it getting stuck at the tip, or is it getting stuck somewhere along the shaft? More often than not, it's at the tip, and if it's possible to zoom in and see what's really going on. If your catheter tip is not moving at all, and the rest of the catheter is, then perhaps you're a little too deep, and you may need to modify that lesion a bit by using a small balloon like a 1.0 Sapphire, or a 1.25 or a 1.5 balloon. If, however, the catheter is moving and you think that the whole thing is rotating, the catheter tip is rotating, and the microcatheter, the whole shaft is rotating, but it's just not advancing, then that typically is a support issue. So again, look at support, look to see whether you need to modify that lesion just at that location. Those are typically the causes. Now, if your turnpike is not moving, then perhaps switch to a turnpike spiral or the regular turnpike. If you started off with a regular turnpike and it's not moving, then switch out to a spiral or turnpike LP. So sometimes just changing your catheter type will make a difference. And in my experience, just my experience alone, switching to a gold does not solve the problem. I think gold works best when you have a lumen that you can't see, you just can't go along it. I think if the catheter is stuck, more often than not, switching to a spiral or a turnpike LP standard size will do the trick.
It's all, and you talked obviously a lot about the different types of catheters, but didn't touch much on the lengths. Can you kind of give us the difference between when you would use a 135 centimeter versus a 150?
Yeah, great question. So, 135 works for me a lot. I would say that 90% of the time, 95% of the time I'll reach for 135. I like it for two reasons. A, because I think the amount of length outside the guide is just appropriate. I'm used to torquing at that length. The 150 sometimes extends out much longer. The other reason really is trapping. I do a lot of trapping. I use the trap liner, and it becomes very hard for me to trap out of 150 just because you really have to shove the trap liner or the extension portion in. So for me, because I'm doing a lot of radial, I'm doing a lot of 6 French, and I do want to use the trap liner, I think the 135 works for most of my antegrade cases. Now, when you start doing a little bit more complex stuff, for example, the peripherals, this hand case, for example, that leg case that I showed you, or perhaps some of the more complex coronary stuff that we may get into, trying to get through sort of maybe you're trying to go down a graft and come up something, or go down across, from one vessel to the other across the surface of the heart. For those type of situations, for wire exchange, I may use a 150. There are times that the 150 just won't cross, and I may use something like a 135 to cross, and then use the 150 to exchange. So again, I would say that for 95% of antegrade, complex coronary, non-CTO cases, the 135 is adequate.
We've had quite a few questions surrounding kind of technique. I think it was in relation to your video you were showing where you were actually showing how you torque with your fingers. Do you feel like there's a huge learning curve to that? Was that an easy skill to master?
The funny thing is, the first time I learned it was on a very complicated lesion. It was a total occlusion, and my proctor was Aaron Grantham, who I love, who's fantastic. And I think Aaron was pulling out his hair. He wanted to smack my hands because I wasn't torquing fast enough. I didn't know what he was talking about. He was getting all frustrated. And so yes, there is a learning curve. I'll tell you that from personal experience. Having said that, though, it's not as steep as you would think. And I think the way I now teach my fellows is I actually have them perhaps practice the torquing motion on lesions that are not very complex. So for example, I know I'm going to use a microcatheter for an exchange. Let's just say this is a relatively straightforward ROTA case or some kind of CSI case. I know I'm going to change out for an atherectomy wire once I've crossed it. So I'll use something like soft to get across, and then I'll just have the 135, and then I will use that motion or that opportunity to teach the fellows how to use that motion. So those of you who have the microcatheter, who are still not comfortable with the torquing motion, just take a regular case where you have to use a microcatheter for exchange or for something else. And then instead of advancing it, even though, yes, you can advance it, instead of advancing it right off the bat, why don't you just use a torquer and hold the torquer with your pinky and just start rotating and get a feel for that, get a feel for what torque feels like, and then you can build it up from there. So there is a learning curve. It's not very steep. My recommendation is don't do what I do and learn this or start learning microcatheters in the most difficult cases. I would start off from some relatively easy cases and maybe start off with a catheter like the Turnpike, which has enough bulk that you can actually feel what's going on. I think Turnpike LP, maybe a little bit more. So sometimes you don't always get that feedback, the tactile feedback that perhaps the Turnpike might give you.
Okay, for this next question, you touched on this a bit when you were talking about the different types of catheters, from the braided to the coiled and the pushability versus the torque. When would you kind of move more towards a more pushable catheter versus a torqueable catheter?
So me personally, maybe I'm the wrong person to ask this question, or maybe I'm the right person. Almost always, I go for the torqueable catheter. I don't think there is enough of an I don't see an advantage to the pushable catheters. And if I can, and I'll just where I'm in life, if I can't get a Turnpike LP to go, a pushable catheter is not going to do the trick. I need to do something else. Either I'm going to modify the lesion tip, or I'm going to anchor, or I'm going to use a guide extender of some sort, maybe a guide liner. But chances are that if my Turnpike LP or if my Turnpike isn't crossing, if that's not crossing, then a pushable catheter is not the issue, it's support issue. So rather than open up a new catheter at that point, I'll probably just try to build up support. So, one way to build up support is change out the guide, just change out the shape, change out the French size. That often requires you pulling the wire back. So you need to have a solution to when you've crossed the stenosis and you don't want to uncross the stenosis. So the real simple solution to that really is a guide extender. Either that, or if you're perhaps working with a 6 French system, or maybe you don't have a guide extender handy, what you can do is put a second wire down some side branch and anchor it. A branch that's perhaps expendable to some degree, and then you anchor it, and then you get the guide seated well, and then you try the microcatheter again. And more often than not, that works, by the way.
Okay, so we are over time at this point, so if you are okay for a few more questions, I can squeeze a few more in now.
Oh, I'm okay. I'm good. I actually thought this was a longer session, so I'm good for another half an hour.
All right. So for users asking a question, they're used to using more pushable microcatheters, and they don't really have a lot of experience with the microcatheters. Is there any advice on maybe the best catheter to start practicing with, to start getting used to this, and any tips that you can offer surrounding that?
Yeah, I think that if you're so many labs will have microcatheters. If you're not already doing the cases, and maybe one of your partners is, you can actually go ahead and see what's on the shelf and use whatever catheter you have. But if you have to, let's just say it's a new job, and they say, hey, listen, give us a wish list. Then I think if I were to wish for a catheter, I think it would probably be either the Turnpike or the Turnpike LP. Personally, I like the Turnpike LP. So if you're comfortable with microcatheters and you're looking to add a microcatheter, maybe for the first time, or add it to the shelf that in the lab you're looking at, and get the LP. However, if you're new to microcatheters right off the bat, or maybe you haven't enough experience, then I think the one to add is a regular Turnpike. And typically I would get 2 of each. 2 of the Turnpike 135, 2 of the Turnpike LP 135s, and maybe 1 each of the 150. But that's up to you. But the point is, if you're learning how to torque, use a Turnpike. If you're comfortable with torquing, or if you're an intermediate or advanced user for torquing, but you just want to start using a catheter more regularly, I think the Turnpike LP is pretty good.
Okay, so our next question, and this is actually a very excellent question. You had talked about tip fatigue and about how the tip can actually get worn out, obviously, the longer this is used. How do you really gauge when you should pull it out and actually examine the tip? And then when you do, what are you looking for? And do you find that it is common to use multiple microcatheters because of this?
So I'll answer the last question first. I don't find it's common to use multiple microcatheters unless I'm dealing with a long length of calcium. So be it a total occlusion or a subtotal occlusion, if I'm going through a lot of calcium, I find that I'm more likely to need a second catheter. And that's partly because I think my style is also a little bit more aggressive in these cases. I hate to admit it, but I torque a lot. I have a lot of support, and I've actually really hurt some microcatheters. But having said that, it's not very common for a non-CTO lesion for me to use multiple microcatheters, but it does happen. All right. The other question, more along the lines of like, when do you gauge when to use it? Well, I think it's something that I guess the best example I would give you, which is kind of a silly example, is it's like turning the key to the front door of your house. Like, you know what it normally feels like. And when that door, when it sticks a bit, you know it's sticking. You know what? I've turned this key so many times. I know that this lock maybe needs oil or something's about to happen. It just doesn't feel like. It's a bit like that. Once you get the feeling of what a normal resistance to the turnpike torque ought to be, even with high resistance, you get an idea for when things are fine. And so if you feel that the catheter is feeling a little gummy, like it's not torquing as well as it should, or when it torqued, it kind of hesitated and then moved forward, or perhaps when you're trying to pull it out, you had to like pull a little harder than you. So when you feel that you have to do things that you're typically not used to doing with the catheter, there may be a problem, sort of a more sort of structural problem with the catheter. At that time, what you do, well, the simplest thing to do is just lay the catheter out. If it's curling up or if it's floppy and exhausted, you know it's exhausted. The next thing you do is you flush it. If you flush it and you see that the catheter actually is flushing cleanly, then you know that the inner PTFE tube is clear. If you can't flush it, then you know there's crud in there. Probably you won't be able to get that out. The third thing to do is to wet your fingers and run it from the hub of the catheter all the way to the tip, just to make sure you don't have any breaks in the outer layer or you don't feel any sort of kinks in the braid. Sometimes you can feel that. And finally is to look at the tip of the catheter to see as best as you can the tip has a nice taper to it. If the tip is bent to one side, if the tip appears to be split, if the tip appears to be in some ways there's almost like squished a bit, then you know that probably the tip is deformed now from pushing against all that calcium in time to change a new catheter. To summarize, I guess you basically just lay the catheter out, visually inspect it, feel it with a wet, 4x4 in your hand or with wet gloves, flush the catheter, and then inspect the tip. And that will solve 99, or let's rephrase that. In 99% of cases, that will tell you what the problem is with the catheter. It's time to change to a different catheter.
So from what I hear you're saying is, obviously with wires, it's very important to have that tactile feel to really tell what the tip is doing. And from what I'm hearing is you feel like these microcatheters also transmit that in a tactile way to the tips. You can actually tell what's going on.
Correct. And actually more so than wires, with some of the problems with these really sort of high-end or high penetration wires is sometimes, they can cut through new intima without you feeling a whole lot, just because there's so much support that the wires are given. With the microcatheter, it's not as subtle. I think you quickly, once you've done about 10 or 15 cases, get a feel for what a microcatheter should feel like. And again, I would say, I'm sort of reinforced it, that learn to use the microcatheter on lesions that are not too super complex. If complexity went from say 1 to like 10 on whatever scale you have in your life, I would start off by using the microcatheter on the 5, 6 complex level cases. Once you become comfortable, then you can start ramping up to like 7 or 8. And I mean not using, I mean the torquing. Once you're comfortable, because then you get that tactile feel of what is, okay, this is my baseline tactile feel. This is how the catheter should feel going through stent struts. This is how the catheter should feel going over a bend that's calcified. And once you have that sort of repository of tactile feeling, then you get an idea of when, when it's time to change. But the bottom line is, if the catheter is not moving and you are torquing, then you've got to ask yourself what's going on there. Yeah.
Okay, thank you so much, Dr. Arain. I think at this point we're already over our time, so we're going to go ahead and end the presentation for tonight.
Wonderful.
We did have quite a few more questions that we'll forward over to you to have to send out to our listeners. And there's one particular question was surrounding how to trap, and we'll follow up with you directly on that technique. But then I'll also have Dr. Arain weigh in.
Essential technique. That's you've got to know how to trap. So trapping is good techniques. The microcatheter. I mean, there's a lot of things we can talk about. Hopefully, there'll be other seminars like this. But you can look me up on the web. I mean, use my email. If you have any questions, reach out to me. I see some familiar faces, some friends I've worked with in the past. I mean, you can call me, I guess. But the point is, or you can submit your questions to the folks at Teleflex. And many times, if I can't answer that, I'm sure their reps in your labs will be able to help you with these.
All right. Thank you so much for your time and expertise tonight. And I wish you all a good night.
Thank you very much. Thank you, everyone.